Let's jump right in. In this explainer, we're going to rapidly break down some seriously high-yield perioperative management cases. We'll be tackling real-world clinical scenarios, analyzing the options, and pulling out those absolute life-saving exam pearls you literally need to know. So let's get to it.
Think about this first scenario. Now notice the wording. We're looking for the least likely risk factor for deep venous thrombosis. Basically, we want the option that's actually protecting against a clot, rather than causing one. Take a quick second and think about the actual physiological impact of each of these options.
All right, if you guessed C, the ambulatory patient, you hit the nail on the head. Why? Well, it's pretty simple. The mechanical action of just walking around naturally activates the calf muscle pump. That continuous squeezing promotes venous return, which prevents the exact blood stasis that triggers thrombosis in the first place. It's literally the exact reason why nurses are always so eager to get patients out of bed the second they can after surgery.
Now, understanding Virchow's triad beautifully illustrates exactly why the other options, heart failure, malignancy, varicose veins, obesity, are just massive risk factors compared to our ambulatory patient. Virchow's triad breaks thrombosis risk into three major dynamic pillars: stasis, hypercoagulation, and endothelial injury. Notice how things like congestive heart failure and obesity really drive that stasis, while a malignancy strongly pushes hypercoagulation by dumping procoagulant mucins right into the system.
Okay, moving from the vascular system straight into the ICU, we've got a really complex patient dealing with massive fluid shifts. We're looking at a 47-year-old male, recent MI, who just sustained a 20% thermal burn, and he's admitted for resuscitation. Out of these choices, what is the single most appropriate monitoring method for someone who's already this compromised?
The answer is B, the Swan-Ganz catheter. And what's absolutely fascinating here is how this highlights the absolute necessity of measuring left-sided pressures during these crazy fluid shifts. Think about it. When you're aggressively resuscitating a burn patient who already has a damaged heart, you are walking a serious tightrope. Push a little too much fluid, and bam, you trigger cardiogenic shock. But the Swan-Ganz catheter actually measures pulmonary artery occlusion pressure, which gives you a super reliable read on the left ventricular end diastolic volume.
The really crucial takeaway is that in severe cardiac disease, the right and left sides of the heart basically decouple. They stop matching up. Because of that, standard central venous pressure, or CVP lines, simply cannot be trusted to safely guide fluid management here. CVP is strictly a mirror for right-sided heart function. So if your patient has poor left ventricular compliance from that recent MI, a CVP line is going to give you deceptively low or high readings that completely miss the actual pressure building up on the left side.
All right, let's step into the regional anesthesia bay and test some anatomical knowledge. Say you're performing an infraclavicular brachial plexus block, targeting the cords deep to the pectoralis muscles. What is the single most common complication you're going to see with this specific approach?
It's B, damage to the phrenic nerve. Even with everyone using ultrasound guidance these days to make things safer, phrenic nerve palsy is still the most statistically likely complication on this list. It actually happens in up to a whopping 25% of vertical infraclavicular approaches, and it leaves the patient with a transient ipsilateral diaphragmatic paresis.
But look at the critical anatomical trade-offs we're making. Yes, the infraclavicular approach carries that 25% risk for the phrenic nerve, but check out the supraclavicular approach. That risk practically doubles to around 50%. Plus, the infraclavicular route is astronomically safer when it comes to pneumothorax, carrying less than a 1% risk. Why? Because your needle trajectory is pointed safely away from the cervical pleura and the cupula of the lung.
Okay, next up, here's a classic elective pre-op clinic case where you have to make a tough call on uncompensated surgical risks. We have a 78-year-old guy, history of CAD, and he wants an elective hernia repair. Which of these clinical findings is a hard stop, a completely valid reason to immediately halt and delay the surgery? It's C. Jugular venous distension is a massive red flag. It tells you the patient is in active, uncompensated congestive heart failure. Putting a patient with active heart failure under anesthesia carries an unacceptably high risk of intraoperative cardiovascular collapse or an acute perioperative MI. Any elective procedure literally has to be stopped in its tracks until that fluid status is medically optimized with diuretics. To understand why this is so deadly, let's look at the timeline of the postoperative preload spike. During the actual surgery, fluid gets sequestered in the third space, right? But on postoperative day 3, all that sequestered fluid rapidly shifts back into the intravascular compartment.
So if a patient has baseline JVD, they are going to get hit with severe pulmonary edema or ischemia on day 3, because that massive volume of fluid rushes back in and overwhelmingly spikes their preload and their myocardial oxygen demand. It's basically a ticking time bomb.
Let's stick with perioperative morbidity for a second and focus heavily on a patient's functional reserves out of smoking, diabetes, hypertension, hyperlipidemia, and age over 70 with limited reserves. Which one really stands out as the major independent predictor of a perioperative MI?
It's E. The big takeaway here is learning to distinguish between chronic factors you can optimize and independent fixed risks that you just can't change. Sure, smoking, diabetes, and hypertension accelerate coronary disease. Absolutely they do. But if they're stable and controlled before surgery, they aren't the biggest immediate predictors of a perioperative MI. However, the non-modifiable biological reality of being over 70 with frailty means the body just doesn't have the functional reserve to scale up cardiac output. It literally can't handle the profound stress of the anesthesia.
Moving rapidly over to the urgent surgical suite, we've got to precisely calculate transfusion timing for a patient with hepatic synthetic dysfunction. So this cirrhotic patient has abnormal coagulation and they need an urgent cholecystectomy. We're planning to give fresh frozen plasma, or FFP. When exactly is the absolute optimal time to administer this?
The answer is C, on-call to surgery. In clinical lingo, on-call to surgery basically means right before the skin incision. You absolutely have to transfuse at this exact moment to ensure those critical clotting factors are actually active and doing their job when the surgical bleeding starts.
And here is exactly why timing is quite literally everything. FFP has a bunch of coagulation factors, but the heavy hitter you need to watch is factor 7. Factor 7 completely decays within a strict 4 to 6 hour window. Because of that incredibly rapid drop-off, giving FFP the day or the night before is a total waste. Those transfused factors will have completely degraded before the surgeon even picks up a scalpel, leaving your patient totally unprotected.
Let's switch gears and drop into endocrine surgery. We're facing a high-stakes preventative question to stop a lethal intraoperative crisis. A 29-year-old woman with Graves' disease is scheduled for a thyroidectomy. Assuming she's already rendered euthyroid with meds, which of these strategies is strictly required to reduce the risk of a thyroid storm in the OR?
The answer is A, Lugal iodine drops. Giving this triggers a wildly fascinating biological response called the Plummer effect. High concentrations of iodine actually stop the cleavage of thyroglobulin. This effectively traps the thyroid hormones right inside the gland for about 10 to 14 days. And honestly, more importantly for the surgeon, it dramatically shrinks the vascular supply to the gland. That makes the physical extraction so much safer and stops a massive, life-threatening hormone dump while they're manipulating the tissue.
Pivoting over to statistical risk calculators, let's look at the limits of our predictive models. We rely on these scores all the time to counsel patients, but one of these options literally cannot be calculated before the surgery actually starts. Which one of these is not purely preoperative?
It's D, the POSM score. Notice how ASA status, Apache 2, and the ACS NSQIP scores all rely 100% on preoperative data, stuff like physical status and routine physiological variables. But POSM? It stands out because you cannot finalize that score until you have actual intraoperative data. You need the operative details, like the total surgical blood loss or the exact extent of peritoneal soilage, to accurately track those outcomes.
All right, racing to the post-op recovery room, we need to immediately diagnose a life-threatening rhythm abnormality. A 50-year-old post-laparotomy patient presents with an ECG showing tall, tented T waves, a depressed ST segment, and a significantly widened QRS complex. What urgent investigation do you need to order immediately?
The answer is D. You urgently need to order serum electrolytes to confirm severe hyperkalemia. Let's walk through these classic ECG changes because they are basically a massive warning siren going off. It starts with those peaked tented T waves. Then, as the potassium keeps rising, P waves flatten out and the QRS widens. Finally, if potassium crosses that 9 milliequivalent per liter threshold, the widened QRS fuses right into the T wave. That creates the smooth preterminal sine wave. When you see that sine wave, it means ventricular fibrillation or asystole is imminent unless you push IV calcium gluconate right then and there to stabilize the heart.
As we wrap up this explainer, consider this final thought as you process these high-yield cases.
Surgical risk is always this incredibly delicate balancing act between a patient's underlying health and the sheer systemic inflammatory shock of the operation itself. So ask yourself, when you are balancing an emergency surgery against severe systemic comorbidities, how do you actually decide when the risk of waiting outweighs the risk of operating? Finding that exact limit before the intervention itself becomes the biggest threat to the patient's life is the true art of perioperative risk stratification. Keep questioning those boundaries.